viral video for so much long time, and now we are meeting back with a very extensive session on nose. So this is from the ENT. So let's talk about all the aspects of nose. Let's cover each and every question. At the end of this, we'll try to uh, solve MCQs also. So let's see. So talking about the external nose is made up of paired structures. The external node is made up of four paired structures. What are the four paired structures? If you see the four paired structure, this is the nasal bone. This is the bone. So actually, the nose is having the nose is made up of four paired structures consisting of cartilage and bone. Consisting of cartilage and bone. Okay, so the nose is made up of both cartilage and bone. So and these structures are the paired structures. So you can see the nasal bone. This is the paired nasal bone. This is the upper lateral cartilage, and this is the lower lateral cartilage. And then we have the sesamoid cartilage, which is the lesser alar cartilage. This is different. This is not lower lateral cartilage. This is sesamoid cartilage. This lower lateral cartilage is also called as alar cartilage. Don't confuse. You can remember it as the nose consists of four paired structures. One is nasal bone, other is upper lateral cartilage. Lower lateral cartilage is also called alar cartilage. Other one is lesser alar cartilage, which is nothing but a sesamoid cartilage. Okay. So if you see here, the nasal bone, a pair of nasal bone, a pair of upper lateral cartilage, a pair of lower lateral cartilage or alar cartilage. The U-shaped cartilages, the lower lateral cartilage, the U-shaped cartilage, they form external nasal opening. The external nasal opening. Lesser alar or sesamoid cartilage, these are the small cartilage lying between upper lateral and lower lateral cartilages. These are sesamoid cartilages. Now talk about you might have heard the term Lyman nasal a lot of time. So let's clarify what is Lyman nasal. So Lyman nasal, it is a junction of upper lateral cartilage and lower lateral cartilage. Upper lateral cartilage and lower lateral cartilage junction is called Lyman nasal. This forms the outer boundary of nasal valve. It forms the outer boundary of the nasal valve. The inner boundary of the nasal is formed by the nasal septum. So we are talking what we are talking about is we are talking about the anterior, and we are talking about the anterior part of the nose. We are talking about the anterior part of the nose, anterior and inner part of the nose. So this one is formed by the nasal septum. This is the inner boundary of the nasal valve, but the nasal opening, outside nasal opening. So this is the inner boundary, and the outer boundary is formed by the Lyman nasal. Lyman nasal is nothing but a junction of upper and lower lateral cartilages. Let's talk about nasal valve. What will happen if the nasal valve is collapsed? You can see this picture. So see in this picture, this is the nasal valve. This is the nasal valve. This is the nasal valve. And if it is collapsed, the outer boundary is collapsed. The inner boundary is formed by nasal septum. The outer boundary is collapsed. Lyman nasal is collapsed. So if you see the nasal valve is collapsed, the person cannot breathe. Okay, so there will be obstruction in breathing. So you can do a test called Cotter's test. What will happen in Cotter's test? Just take 2 fingers and push the cheek away laterally. Okay, put 2 fingers on the cheek and lift the cheek upwards. So what will happen? The valve will open, the collapsed valve will open, and the person will be able to breathe. So there will be enhancement in the breathing. Okay, that is the collapsed nasal valve. Talking about the defects in external nose. So the external nose can have defects. So if you see this nose, there is a defect here. This is the saddle nose defect. We'll see what is that one by one. The saddle nose defects means it is a depression. It is a depression. Means it is a depression on the dorsum of nose. So if you see like this. So here the dorsum of the nose, here there is a depression. So here there is a depression. The depression is can be due to many causes. Mostly the nasal septum is involved here. The causes can be septal surgery. There might be some surgery. And because of especially the submucosal resection, SMR surgery. Like previously, the surgery which was done for deviated nasal septum as submucosal resection, in which a lot of cartilage, mucosa, and bone has been removed. So that can lead to saddle nose. Or due to trauma, the bone has been damaged and it has been removed. So because of that, leprosy. So especially the last stages of leprosy, the leprosy can cause the um, damage to the cartilage. The bacteria will eat upon the cartilage. The syphilis, especially the tertiary syphilis, this can lead to damage to the cartilage, saddleness, and tuberculosis. Okay, what will be the treatment? Treatment will be rhinoplasty, augmentation rhinoplasty by using iliac crest graft. There, because the bone is already damaged, there you have to use the graft. From where you can use iliac crest, the ilium bone of your pelvis. From there the crest can be used for the graft. Hump nose. What is hump nose? Hump nose is where in saddle nose the bone was less. Here the bone is more. It is also called crooked nose. You can see how it is looking. The bone and the septum is so much enlarged. Okay, the convexity of the dorsum of nose, you can see, maybe due to trauma, due to birth. During birth, if there is a trauma, it can occur. Opposite to saddle nose, treatment surgery, reduction rhinoplasty. There augmentation where we are using iliac crest, but here you are using reduction rhinoplasty where you are removing some bone, cartilage. If midline gets deformed, there can be two types: crooked nose or deviated nose. So here we can have two varieties. One is crooked nose. Here the speciality of crooked nose is that the dorsum is deviated but the tip is in midline. The dorsum is deviated but the tip is midline. But here in deviated nose, dorsum and tip both are straight but deviated to one side. Deviated and tip are straight but both are deviated to one side. They are straight, but if you see the picture you can come to know. Here if you see, the nose is deviated, but at the end it is coming to midline, but here everything is deviated. See here, it is totally deviated. You can see something like it's not working. Okay, it is totally deviated, but here if you see, it is deviated, but in the end it comes straight. So see here, dorsum is deviated but tip is in midline. This one only deviated. This is at the tip line, at the tip midline. But here if you see here, the dorsum tip are straight but both are deviated to one side. Here they are deviated to this side. Okay, they are straight but deviated. Here this one is only deviated. This is straight. Okay, this is called crooked nose. At the end it is coming at the midline, but this is at the end it is deviated to one side. Deviated nose. Basal cell carcinoma. Basal cell carcinoma is also called a rodent ulcer. It is the most common malignancy of skin of external nose. If external nose skin malignancy is coming, most common is basal cell carcinoma. Think of basal cell carcinoma. It is present as an ulcerative telangiectatic lesion with rolled out edges. The edges are rolled out. Slow growing cancer, lymph node metastasis can be seen, but is rare in basal cell carcinoma, and wide surgical excision can be done. So if you see here, this is the rolled out edges. The edges are rolling out, rolled out edges. And if you see the blood supply, so much telangiectatic blood supply, like that blood supply is the telangiectatic blood supply. Let's talk about rhinophyma. What is rhinophyma? Potato nose. It is also called potato nose. Here you see there is no malignancy here, but there is only a hypertrophy of the sebaceous glands which are present on the skin of the external nose. Hypertrophy of sebaceous glands. Sebaceous glands, they form the sebum. They form the sebaceous gland. They form the sebum. So the sebum forming sebaceous glands are hypertrophied. Because of that, the nose is looking potato-like. It is more commonly seen in males because of acne rosacea. It is a type of acne rosacea. This is the previous year question. Acne rosacea. Okay, it is not related to alcohol consumption. Laser excision and skin grafting. You remove it with the sebaceous gland and then graft it. Clinical scenario based question here. A young child with cystic swelling in or around the nose. So what are DDs? What is the investigation? Investigation choices CT scan. Why CT scan? Because there are three possibilities. One is nasal dermoid. Any mass growing on the midline structure is a dermoid. It is encephalocele. Encephalocele is along with the meninges of the brain. The swelling is there. And the swelling, there is a meninges of the brain. Glioma is the meninges have been cut, the connection with the brain. But here the meninges have the connection with the brain in encephalocele. Let's discuss in detail here. So you see here, baby is having a midline mass. This is called simple nasal dermoid. But here there is no mass, but you can see a sinus. Sinus. This one is connected inside. Okay. So what is a nasal dermoid, guys? What is a nasal dermoid? Nasal dermoid is a simple nasal dermoid. It is a cystic swelling in midline. Cystic swelling in midline over the dorsum of the nose. Over the dorsum of the nose. Is audio video proper? Am I live? यहाँ अगर रिंग गिराई तो नौकरी गई. 1 second. यहाँ अगर रिंग. Okay. Let me check once. Everything is going properly. Yeah. So we are live. Yes. Okay. Well. Okay. So we are talking about nasal dermoid. What is a nasal dermoid, guys? Nasal dermoid is. What is a nasal dermoid? It is a simple nasal dermoid is a cystic swelling in the midline over the dorsum of nose. Midline swelling is a dermoid. So nasal dermoid is a cystic swelling. There can be nasal dermoid with sinus openings, as you have seen in the picture. This sinus can have intracranial communication. That's why we do CT to see the communication before excision. That will be helpful for the surgery. Surgical of dermoid with sinus tract. Okay. Let's next. This is the with sinus. This one is simple. Okay. Nasal dermoid with hair present in sinus opening. Here there is a hair. Here also. Nasal encephalocele. It is most serious because along with the cyst there is a herniation of brain and meninges into the roof of the nose. Okay, this swelling can be pulsatile swelling, reducible, and increases in size on coughing or crying. So this is called Furstenberg test. Furstenberg test. Okay, so if you see in encephalocele, the thing is this is the herniation of the meninges of the brain and the brain structures into the roof of the nose. Okay, so how can you detect it? How can you test it clinically? that is there any connection with the brain or meninges or not. How will you detect it? By Furstenberg. So you can ask the person to cough or cry, or induce, like if it is a child, you can stimulate the child to cry. So then what will happen during crying? There will be pulsatile swelling. The swelling size will increase, and in coughing you can see increase and then decrease. This will increase in size on coughing or crying. Furstenberg ask the patient to frustrate, crying or coughing. Okay, a trick to remember. Okay, frustrate or Furstenberg sign. Now, glioma. In glioma, there is an encephalocele, but there is no long connection with the brain or meninges. There is no connection. Only the remnants of meninges are there in the glioma. Okay, in nasal glioma, Furstenberg test is negative because there are no connection with the brain. Lateral wall of nose. Let's talk about lateral wall of nose. So wall of nose is there now. It is having turbinates. Lateral wall of nose is having turbinates. These are projections on the lateral wall of nose. There are three turbinates. There are three turbinates in the nose. Okay, how many turbinates? Three turbinates. What are the turbinates? It is the bone with the mucosa. Okay, it is called turbinate. So there are three turbinates. If you see here, inferior turbinate, middle, and superior turbinate. See here. This is the turbinate. This is the superior turbinate, middle turbinate, inferior turbinate. So how many turbinates are there basically? In those three turbinates. So below the turbinates you'll be having a space called meatus. So below the superior turbinate, superior meatus. Below the middle turbinate, middle meatus. Below the inferior turbinate, inferior meatus. So there are three meatus since there are three turbinates. In some people, in some special people, there is a supreme turbinate. There is a supreme turbinate. There is a supreme turbinate in some people. Okay, extra turbinate, that is called supreme turbinate. Superior से भी ऊपर. Above the superior turbinate, the supreme turbinate. We were calling the area below the turbinates as the meatus, inferior, middle, superior meatus. But below the supreme turbinate, we call it as sphenoethmoidal recess. We call it as sphenoethmoidal recess. The area the area above the superior turbinate. Okay, this is the area above the superior turbinate. Yeah, above the superior turbinate or below the supreme turbinate is called sphenoethmoidal recess. Sphenoethmoidal recess. Sphenoethmoidal recess. Okay, anatomical variations. Some people have extra turbinate because supreme turbinate. Okay, concha. So if you once again see this is the turbinate. This is the turbinate, and you can see a space between. So below the each turbinate you have meatus, and above superior turbinate you have sphenoethmoidal recess, not turbinate, recess. What is concha? Concha is the bony part of the turbinate. Concha is the bony part of the turbinate because I said the turbinates are made up of bone and the mucosa. So the bony part is called the concha. So there are three concha: inferior concha, middle concha, superior concha. So it is an independent bone. So if you see the superior and middle turbinate, these are the part of ethmoid bone. But inferior turbinate is an independent bone hanging. Okay. If you see this diagram, so the lateral wall of nose, and these are the turbinates. So the inferior concha, this one is the independent bone. Okay, whereas the other are the part of this one. These one are the part of the ethmoid bone itself. So here if you see the picture image, this is the inferior turbinate. This one is a different color. This is the inferior turbinate. Below that you will have inferior meatus, and this is the middle turbinate. Below that you have middle meatus. Okay. Okay. What is choana? We have seen concha. Some people get confused. Just now you teach about choana. Choana is different. Concha is different. Concha is the bony part of the turbinate. Choana is the posterior opening of the nasal cavity. You see, you have nose. Mind me for my drawing. If you see the nose, the externally, you will see two openings are there. These two openings are called the external openings, external nares. Similarly, we have internal one which connects the nose, nasal cavity to the nasopharynx. Because pharynx have three parts. Pharynx have three parts. What are the three parts of pharynx? Nasopharynx, laryngopharynx, and oropharynx. So we have three parts of pharynx. So this one is the nasopharynx opening. Okay, what is choanal atresia? Atresia is what? Not well developed. Okay, so it is a congenital disorder. Choana is a not patent here. Patient not patent here. It is due to persistence of bucco-nasal membrane. It is due to persistence of bucco-nasal membrane after birth. It can be unilateral or bilateral. But if it is bilateral, it is lethal. It can be bony or membranous. It can be complete. It can be bony or membranous because we are saying bucco-nasal membrane, bony or membranous. The bony or membranous thing can be, mostly it is bony. Most commonly it is bony. Why it is bony? Since it is bony, the person cannot breathe. See, if the openings are blocked, if the unilateral is there, with the other nose, the baby can breathe because this is the congenital thing. If both are blocked, baby cannot breathe. And the infants, they are obligate nasal breathers. They cannot breathe with mouth like adults. So it is a neonatal airway emergency if it is bilateral. Okay, because neonates are obligatory nasal breathers, mouth breathing is acquired reflex. Baby is cynosed immediately after birth, but turns pink on crying. Blue baby turns pink on crying. Immediate management is putting white bone nipple in baby's mouth to keep the mouth open and breathe from the mouth. It's called McGovern's technique. And then what happens? Immediately baby is born, baby is totally blue and stimulated, then the baby is crying, turning into pink. So what will happen when you try to pierce the nasogastric tube, pass the nasogastric tube through the choana, then the choana is blocked. The nasogastric tube cannot enter into the stomach. Okay, so here you can see you can put the white bone nipple in the baby to help the baby breathe. So this is the white bone nipple. So normally, how is the nipple? Hmm. Like this. So this is very small, but let's take it and cut it. So this is the white bone nipple. Now the baby can breathe through this, and baby will also be silent. But how many days it will do that? So what we do is we put a emergency tracheostomy will help the breathing. But okay, after 1 year, plan for the recanalization surgery, endoscopic surgery, where through the endoscope the choana can be opened. So this is the normal choana with the opening patent here, but here the choana is closed. Choanal atresia. Let's talk about nasal science. We are moving very fast, right? We have so much, but we are quite fast, dealing only with the important aspects, right? We have to cover nasal polyp, allergic, all these things. Neoplasms also. Facial trauma also we have to do. Epistaxis, most importantly. Miscellaneous topics of nose. Important and interesting topics coming. So do not leave the session. Be till the end. We will learn so much. It will be very helpful. Okay. So moving on to the next, that is paranasal sinuses. Okay. So what are paranasal sinuses? Sinuses are the hollow cavities in the skull bone. These are mucosa lined, air filled hollow cavities in the skull bone. These are air filled and hollow cavities in the skull. Because you see, there is no air filled cavities, the skull will be very heavy, and the skull is only balanced through the vertebrae in the neck, and there is no other structure supporting the neck. So the air filled cavities help the skull to lose some weight. Okay, lose some weight, and to stabilize the skull. So they are ventilated during expiration. They are also ventilated, but during expiration. Unlike inspiration, the nose and the larynx, everything is ventilated. The nose and paranasal sinuses are lined with a respiratory mucosa composed of pseudo-stratified ciliated columnar epithelium. So you see a nasal cavity is lined by pseudo-stratified columnar epithelium. Similarly, the paranasal sinuses are also lined by pseudo-stratified ciliated columnar epithelium with mucosa. Mucosa of paranasal sinuses secrete the mucus. They secrete mucus, and this mucus is drained into the nose through the opening of sinus called ostium, and they are swallowed then. Okay, so this mucus is drained into the nose through opening of sinuses called ostium. This is the ostium. This is the ostium. Ostium opens into the nose. Okay, this because of ciliary motility, because we have cilia, pseudo stratified ciliary, but then the cilia move towards the nose. Nasal cilia moves backward at the speed of 10 to 20 beats per second to push mucus towards the choana to nasopharynx. To nasopharynx, 10 to 20 beats per second. 10 to 20 beats per second. The mucus moves towards the choana of to nasopharynx. 10 to 20 beats per second. 10 to 20 beats. Nasal mucociliary clearance time for mucus to reach from anterior end of nose to the posterior end of choana is 10 to 20 minutes. So this is also a previous question. So nasal mucociliary clearance time for the mucus reaching from the anterior end of nose to the posterior end choana takes 10 to 20 minutes. Anterior end of nose to posterior end, it takes 10 to 20 minutes. Ciliary defect can lead to sinusitis. Ciliary defect can lead to sinusitis. There are four pairs of sinuses. What are the four pairs of sinuses? Maxillary sinus, ethmoidal sinus, sphenoid sinus, and frontal sinus. Okay, you're dealing with it. Let's see. This is also called antrum. The maxillary sinus is also called antrum of high mode. The other name of maxillary sinus is antrum of high mode. Antrum. We have seen at antrum polyp, maxillary polyp. Okay, this is the largest sinus, maxillary sinus. Name में ही है ना, max मतलब maximum size. So this is the largest sinus. The volume is 15 ml. 15 ml fluid you can store in the maxillary sinus. So it is pyramidal in shape. See, it is pyramidal in shape. Okay. Next. What are the boundaries? Base of maxillary sinus is towards the lateral wall of nose. The base is towards the lateral wall of nose. Apex of maxillary sinus. Oh my god. The apex of maxillary sinus is towards the zygomatic area. This is zygomatic area apex. Floor of maxillary sinus related to floor is related to premolar and first molar. Second premolar and first molar dentition teeth. So if you go above second premolar and first molar, you will find the maxillary sinus floor. floor. Okay, floor. Maxillary sinus drains into the middle meatus. It drains into the middle meatus. We have seen that three turbinates, and below each turbinate we have empty space called meatus. So middle meatus means there is an opening of maxillary sinus. There is accessory ostium seen in 30% cases. Oroantral fistula. Oro means mouth, antral means maxillary sinus. So there can be formation of oroantral fistula if during the extraction of second premolar and first molar this goes deep. It will reach into the floor of the maxillary sinus leading to oroantral fistula. What is the frontal sinus, beta? What is frontal sinus? Above the orbit is the frontal sinus. If you see the orbit, there is a frontal sinus, and below the orbit is maxillary sinus. The orbit, above the orbit is frontal sinus, below the orbit is maxillary sinus. Frontal sinus is most asymmetric pair of sinuses. It is asymmetric, and right and left can vary a lot in size. Frontal sinus ostium opens into frontal lesion, which drains into middle meatus. Maxillary also drains into middle meatus. This also drains into middle meatus. It is also draining into middle meatus. So frontal sinus ostium opens into the frontal recess, which opens into the middle meatus. From middle meatus, that is anterior nasal cavity, reaching to the posterior nasal cavity, it takes 10 to 20 minutes of time. Sagittal section of CT. So this is the, let's see, this is the frontal ostium. Frontal sinus opens into frontal recess. From recess it opens into the middle meatus. So sinuses open into the ostium. Through the ostium they open into the frontal recess to the middle meatus. Okay. This sagittal section of CT you can see. Sphenoid sinus. Sphenoid sinus is the deeper one, okay, which lies behind the orbit. Parental sinus above the orbit. Maxillary sinus below the orbit. Sphenoid sinus behind the orbit. So they are all related to orbit. Sphenoid sinus lies behind the orbit. Sphenoid bone is pneumatic bone with a pair of sphenoid sinuses. Pneumatic bone means in the bone small spaces are there. It is also an asymmetric pair of sinus after frontal sinus. Frontal is the most asymmetric one. So now relations to sphenoid sinus. This is very high yield. Let's see this. So this is sphenoid sinus, and in the sphenoid sinus you see here this box like things, the sphenoid sinus inside, and inside you can see the cavernous sinus is there. So this is the body of sphenoid, this is the ethmoid, these are the orbits. Okay, this is the sphenoid sinus. So here you can see it is related to the cavernous sinus directly. So any complication relating to sphenoid sinus can lead to complication of cavernous sinus. Therefore, sphenoid sinusitis can lead to cavernous sinus thrombosis, which is the intracranial complication, very severe intracranial complication. Lateral wall of sphenoid sinus is related to optic nerve also, and internal carotid artery. Internal carotid artery, optic nerve, cavernous sinus. So it is related to cavernous sinus, optic nerve, internal carotid artery. Therefore, optic nerve injury and ICA injury can be a complication of sphenoid sinus surgery. Roof of sphenoid sinus, this is very important, consists of pituitary gland. Which gland? Pituitary gland. Pituitary gland lies in the sella turcica, and sella turcica is a depression within the sphenoid bone itself. So depression in the sphenoid bone, so it contains the pituitary gland. The thing is, you can use the sphenoid sinus to approach the pituitary adenoma. Removal by the endoscopic transnasal transsphenoidal approach. This is the sella turcica that pituitary gland is lying, and this is also sphenoid sinus. So you can approach endoscopically with the sphenoid sinus, break this sella turcica, grab the pituitary, and remove the adenoma. Very simple. Don't have to break the skull and go deep. I have to just do endoscopically do transsphenoidal approach. But the complication, damage to internal carotid artery, damage to the optic nerve can occur. So pneumatization of sphenoid sinus. Pneumatization of sphenoid sinus. Concha. So these pictures are very important here. The concha is very small is there. This 5%. Precellar is also small. But it's a post-cellar which is 67%. It's very huge. So conchal is 5% only, 5% of sphenoid bone. Pneumatization. Precellar is only 23%, 23%. This is 5%. This is 67%. It's huge difference. Cellar post-cellar, this is the commonest pneumatization, and commonest is the post-cellar. Ethmoid air cells, ethmoid sinus. Ethmoid sinus is not a single cavity. It is not a single cavity, it is a collection of multiple air cells. Now, ethmoid sinus is a collection of multiple air cells that are divided into bony plate called ground lamella or basal plate. Big hollow cavity in skull sinus, small hollow cavity in air cells. Big hollow cavity in skull sinus, small hollow cavities in air cells. So general concept is big hollow cavity in skull sinus and small hollow cavities in air cells. So why we are calling ethmoid air cells? Why we are not calling ethmoid sinus? Why we have given both names? Because this ethmoid sinus means big cavity, hollow cavity. Air cells means small cavities. Ethmoid bone is a single bone between two orbits. This bone is the ethmoid. Contains ethmoid air cells, which contains ethmoid air cells. You see here. This is all ethmoid bone. This is all ethmoid bone, and here you can see the small air cells. And this is the perpendicular plate of ethmoid forming the nasal septum. See, this is the ethmoid air cell. Okay, this is the lamina papyracea. This is a small thin paper-like bone between the orbit and the stomach bone. Forms medial wall of orbit. This perpendicular plate of nasal septum, and this is the cribriform plate of ethmoid from where the nerves enter, olfactory neurons. Okay, and this is the ethmoid itself. Ethmoid bone parts. Cribriform plate is part of ethmoid bone. Okay, olfactory neurons pass through the cribriform plate of ethmoid. Perpendicular plate of ethmoid forms part of nasal septum. Septal cartilage joins the perpendicular plate of ethmoid to form nasal septum. It forms the nasal septum. How perpendicular plate? Because the septal cartilage joins the perpendicular plate and forms the nasal septum. Lamina papyracea forms medial wall of orbit, and medial and superior concha are part of ethmoid bone. So ethmoid bone, all features are there. One is cribriform plate of ethmoid where the olfactory nerves pass. Other is perpendicular plate of ethmoid which forms the nasal septum. Other is lamina papyracea, which is a paper like a partition between orbit and the nose. And middle and superior concha. Inferior is the separate independent. Inferior is independent. Inferior is independent. Middle and superior are ethmoidal part. Ethmoid air cells are divided into two groups by a bony plate called ground lamella or basal lamella. The ethmoid air cells, the ethmoid is divided into two groups by this one. This is ground lamella or basal lamella. The groups are called anterior and posterior ethmoid air cells. Okay. The anterior ethmoid air cells, posterior ethmoid air cells. The anterior ethmoid air cells having 2 to 8. Two anterior cells are constant, but 2 is constant. Okay. Posterior is 1 to 8. Two constant anterior ethmoid air cells are 2 are constant. 8 can be there, but 2 are very constant. Bulla ethmoidalis, most common and largest anterior ethmoid bulla. It's like a bull. It is very large. Bull is large, right? Second is which is anterior most. It is very आगे है. Second one is agar nasal, which is very आगे in the anterior ethmoid also. Anterior most. It is always constant. Bulla is the big one. Bulla is the bulla ethmoidalus. It is the big one. Okay. And agar nasal is आगे है in the anterior of the anterior ethmoidal. Radiological appearance of ethmoidal is yeah. Black only. Okay. Agar nasal is the anterior most. Agar nasal is very constant in the anterior throat. Anatomical variation. This one is the agar nasal. Agar nasal bulla thoda is. Ethmoidal bulla is the largest one. Let's talk about anterior anatomical variation. Some people ethmoid is unusual locations. Depending upon these locations, these cells are given unique names. Concha bullosa, Haller cell, and Ornodie cell. See, concha bullosa, what is that? Anterior ethmoid is lying inside middle turbinate. मिडिल टर्मिनेट के अंदर ही रहेगा तो नेमेटाइजेशन ऑफ मिडिल टर्मिनेट this is the middle terminate, this is the inferior one, this is the middle terminate, so here it is lying, so here this is called concha bullosa. All sinuses like maxillary sinus, frontal sinus, they open into the middle terminate, but this ethmoid itself is in the middle terminate. Concha bullosa is also big. Most common variation can lead to cellulitis. Haller cell. Anterior ethmoid is lying on orbital floor. The floor of the orbit, it means it is very near to the orbit. This is the orbit. This is the floor. Ornodie cell, part of posterior ethmoid cell lying close to optic nerve. Ornodie cell, part of posterior ethmoid cell lying close to optic nerve. Posterior ethmoid cell lying close to optic nerve. So Ornodie cell is part of posterior ethmoid lying close to optic nerve. Ornodie, optic nerve. O means eyes ka optic nerve. Ornodie is optic. Concha bullosa is middle terminate. Other is Haller cell. It is the help. It is in the floor of the orbit. Unusual locations: orbital floor, Haller cell, close to optic nerve, Ornodie cell, inside middle terminate, concha bullosa. These cells can lead to complications during endoscopic sinus surgeries. And most variation out of these can lead to sinusitis. So all three are shown here. Haller cell, concha bullosa, and Optic nerve. Ethmoid sinus, middle turbinate, nasal cavity. Concabulosa in the inferior turbinate. Middle turbinate, in the middle turbinate. These one you are able to see below the orbit maxillary sinus. These are ethmoids. Sinuses. Development of sinuses. We have talked about bilateral sinuses. Okay? So how these sinuses develop. Now we are talking about the development. Occurs in this order. Radiological development is MESF. First maxillary, ethmoid, sphenoid, then frontal. Last and then we will see frontal. First you can see maxillary. Maxillary is present at birth. Rapid growth from birth to 3 years. Adult size 15 years, 4 to 5 months after birth. The birth at the time of birth, the maxillary sinus is present, and rapid growth from birth to 3 years. Adult size it will take in 15 years. So 4 to 5 months after birth, you can see radiologically. Ethmoid present at birth reach adult size by 12 years. Radiological evidence after 1 year. Not present sphenoids is not present at birth and reaches sella turcica by the age of 7 years. Northern cella by late teen and reaches sphenoid 4 years. Adult size 15 years. Frontal not present. Frontal not present at birth. Sphenoids not present at birth. Invades frontal bone at the age of 4 years and increases till 6 years radiological appearance. Structures draining into the nasal cavity. Middle turbinate we have seen. Middle meatus. So let's see. Nasolacrimal duct, inferior meatus. Nasolacrimal inferior meatus. Okay. Whenever you cry, you may see the tears come out of it. They are present in the inferior meatus itself. Maxillary sinus, middle. Frontal, middle. Anterior ethmoid, middle. So these three are middle. Sphenoid will not come down. It is behind the orbit, so it will be there in the sphenoethmoidal recess. What is sphenoethmoidal recess? Above the superior turbinate, the space recess. Posterior ethmoidal, superior meatus. Most sinuses open into middle meatus. Lacrimal apparatus and chronic dactyl cystitis. Surgical opening of DCR. How it is made? Is made into middle meatus. Actually, the DCR, this one, nasolacrimal duct, they open into the inferior meatus, but if we go through the middle meatus and open the lacrimal sac directly into the middle meatus. It is the case of chronic dactyl cystitis due to nasolacrimal duct blockage. So there is a valve here in the nasolacrimal duct that is called valve of Hasler. So if this is blocked, what we do first, we give the massage. Massage is not working. We do the dilation and we do the needling. If it is not working, then we do probing. Then if it is not working, go for the surgery to the middle meatus. Okay. This is the Kerison's endoscopic DCR punch. Kerison's. Middle meatus, most important area of sinus drainage. All sinuses, it has 4 landmarks which are described here. 4 landmarks inside middle meatus. So inside middle meatus we have uncinate process, bulla ethmoidalis, and hiatus seminocalis. So, uncinate process is a sickle-shaped bone which covers bulla ethmoidalis, part of ethmoid bone. Most constant and largest. Ethmoidal infundibulum space between the uncinate process and bulla ethmoidalis. Hiatus seminocalis is a entry, imaginary two-dimensional entry door entry door in the of ethmoidal infundibulum. What is ethmoidal infundibulum? Space between uncinate process and bulla ethmoidal. So what is uncinate process? Uncinate process is sickle-shaped bone which covers bulla ethmoidalis. Okay, most common largest anti-ethmoidal hair cells. What is osteometrial complex? This is important. Osteometrial complex. It is also called Piccardis circle. Also called Piccardis circle. So maxillary sinus, frontal sinus, anterior ethmoid hair cell. Maxillary sinus, frontal sinus, anterior ethmoid sinus cells drain into the ethmoidal infundibulum area of medial meatus. This whole complex is called osteometric complex. What is ethmoid? Bulla ethmoidalis? Most constant and largest anterior ethmoid hair cell, part of ethmoid bone. So this is the bigger one, bigger hair cell of ethmoid. What is uncinate process? Sickle-shaped bone which covers bulla ethmoidalis. Sickle-shaped bone which covers the bulla ethmoidalis. Bulla ethmoidalis is covered by sickle-shaped bone. Sickle-shaped bone which covers the bulla ethmoidalis. Is a part of ethmoid bone. And the space between the uncinate process, what is the uncinate process? Sickle-shaped bone covering the bulla ethmoidalis, and the space between the two. This is the sickle-shaped bone which covers the bulla ethmoidalis, which is the large ethmoid hair cell in the middle. Large ethmoid hair cell. So, okay. So ethmoidal infundibulum. Okay, 1 minute. This space between them is called ethmoidal infundibulum. This is called ethmoidal infundibulum. This is the uncinate process. This is the okay. Anyways, this is the so the space between them two is called the ethmoidal infundibulum. Hattus semilunaris is the imaginary door entering into the ethmoidal infundibulum. What happened to this? Anyways, understood now. Okay, I got it. So this is the uncinate process, sickle-shaped one. This is the uncinate process. Okay. Bulla ethmoid. And this space is called ethmoidal infundibulum. and the door to that is called the hiatus semillonaris. This one is incident process. This one is bulla ethmoidalis. This one is ethmoidal infundibulum. This one is hiatus semillonaris. Okay. Osteometal complex is the maxillary sinus, frontal sinus, anterior ethmoid cells drain into the ethmoidal infundibulum of middle meatus. The whole complex is called osteometal complex. Maxillary sinus, ethmoidal sinus drain into the ethmoidal infundibulum area of middle meatus. This whole complex is called osteometal complex. Osteometal complex or ostia are opening into the meatus. It's called osteometal complex. All ostia opening into the middle meatus. Where they are opening? They are opening in ethmoidal infundibulum. Ethmoidal infundibulum. So the whole complex is called osteometal complex. So osteometal complex is nothing but bulla ethmoidalis plus anterior process plus ethmoidal infundibulum plus three sinuses. Bulla ethmoidalis anterior process ethmoidal infundibulum plus three sinuses opening into the meatus. It is also called Piccadilly circle. Piccadilly circle. Finally, coming to sinusitis. Osteometal complex key pathology area in sinusitis is osteometal complex. Osteometal complex is blocked due to mucosal edema. The blockage of sinus drainage. We said that the sinuses lined by pseudostratified the ciliated epithelium. So these epithelium, they are constantly secreting some mucus. And this mucus is draining through the ostium into the middle meatus, osteometal complex. So if this is blocked, then all will be here only. So it can lead to collection. Collection can lead to infection. Sinusitis. If it persists for more than 3 months, chronic rhinosinusitis. Take a presentation. How will the patient present to you? My nose is obstructed. Purulent nasal discharge, it will be purulent. Purulent means bacterial. Pus is there. Post nasal drip. Halitosis, bad smell from mouth. Hyposmia, decreased sense of smell. Facial cheek pain, maxillary sinusitis, headache. Different types of headache, facial pain indicative of different types of sinusitis. If the patient complains that when I'm bending the head, I'm getting headache, is frontal sinusitis. Office headache or periodic headache. The patient is sitting and focusing on the device. Office headache. Occipital or vertex headache. Occipit vertex headache is sphenoid sinusitis. Pain at medial canthus, ethmoid. Because ethmoid is at the medial, right? So ethmoid. Pain over cheek. If the patient is complaining, they are maxillary sinus. This maxillary sinus is the pyramidal sinus present below the orbit and the cheeks. Sinusitis investigations and treatment. 30 or degree nasal endoscopy is used in DNA, diagnostic nasal endoscopy. First pass along inferior turbinate, then second pass above middle turbinate, then third is inside middle meatus. Okay, diagnostic nasal endoscopy, 30 degree endoscopy. X-ray paranasal sinuses. Waters view, open mouth. We will continue on the next